Public Health Subcommittee meeting, January 13th, sound check 2, sound check 2.
Good morning and welcome to the Public Health Subcommittee meeting for January 13th, 2025. We have quorum present for today's meeting, so I'd like to call this meeting of the Public Health Subcommittee to order. A reminder to everyone that if you have an electronic device that makes sounds, make it not make sounds, please, just not to interrupt yourself or others. I'll move right into our agenda, and the first item is approving the agenda. So can I have a mover and a seconder to approve the agenda as presented? Moved by Member Danko, seconded by Councillor Cassar. Are there any amendments from committee members to the agenda for today? Not seeing any. We'll use show of hands here since not everybody has access to the electronic voting system. All those in favor of the agenda being approved? That's everybody, so that carries. Thank you. On to declarations of interest. Are there any declarations of interest for today? Anyone have a disqualifying or non-disqualifying interest they want to let us know about? Not seeing any, we'll move on to item 4, which is the approval of the minutes from our first meeting on December the 4th, 2024. Can I please have a mover and seconder to approve the minutes of our December 4th meeting? Moved by Member Kirkby, seconded by Member Lennox. Any discussion on the minutes from our last meeting? Any quibbles? Okay, not seeing any. All those in favor of approving the minutes of our last meeting? That is everyone, so it's carried. Thank you. And we're right into delegations today, and so today we'll have a virtual delegation that's pre-recorded. Just to let you know how it's going to work in terms of people want to make comments or questions. You can't question someone if they're not here, and so a pre-recorded video will not allow for questions, it turns out. But when we go to receive the presentation of the video of the delegation, we'll have a space there if anyone wants to make a comment or say anything at that time. So I'll look to you all then if you'd like to make a comment or enter into discussion about the delegation. Otherwise, whenever clerks are ready, they can put it on the screen.
Water fluoridation effects on the immune-compromised and unborn very young. I'm Monica, and I'm an orthomolecular holistic health and cancer practitioner here in Hamilton. Next slide. Some countries began water fluoridation in 1945.
Sorry, just a quick
dental
second here.
cavities can be reduced.
I'm not seeing any video, but I was hearing the delegate refer to next slide. Is it just audio only?
It's audio only, and I think what the delegate was intending is that you'd use the material that she provided, which is included in the agenda as she speaks.
Thanks. I just want to make sure we picked up on that visual cue. Carry on, sorry. Thank you.
Water fluoridation effects on the immune-compromised and unborn very young. I'm Monica, and I'm an orthomolecular holistic health and cancer practitioner here in Hamilton. Next slide. Some countries began water fluoridation in 1945, saying that dental cavities can be reduced by up to 25%. This is the same era where lead in gasoline and paint, asbestos, aluminum, and smoking were deemed safe for the public. Most countries in the world refuse to fluoridate, mostly because of health risks, and some use the precautionary principle because there is limited proof that it was necessary or safe for the public at large. By the late 1990s, many countries stopped fluoridation or greatly reduced the added amounts. Fluoride is not an essential nutrient. Most foods contain fluoride. Hamilton Water and Distribution website states, fluoride is already a naturally occurring material found in our environment, such as water, rocks, air, plants, soil, most foods. Next slide. Currently, only about 4 to 5.7% of the world population have artificially fluoridated drinking water. Australia, Canada, and US have the highest populations. Approximately 170 Canadian communities fluoridate, and 76 of those are in Ontario. The US is looking at stopping fluoridation altogether. Next slide. The Hamilton Water Treatment website states that fluoride is added to the drinking water to promote dental health and maintains levels of 0.6 parts per million. Lake Ontario is 0.15 parts per million. So Hamilton's drinking water is 4 times the naturally occurring level of fluoride. The fluoride added to the water is an industrial byproduct, and it is not the same as naturally occurring calcium fluoride found in foods and natural water bodies. Cavity rates have declined just as rapidly in non-fluoridated countries because of better dental hygiene, oral health education, and restricting sugary foods and drinks. Fluoride is very corrosive and reacts with Hamilton's lead pipes, causing lead to leach into the water. Orthophosphate is being used to reduce the lead leaching, but what doesn't stay in the pipes gets absorbed into our bodies. Material safety data sheets have serious health warnings and also state that fluoride is corrosive to metals, concrete, and glass. Do not discharge onto ground, into drains, lakes, streams, ponds, or public waters. In 2014, the Lancet Medical Journal classified fluoride, arsenic, lead, and mercury as neurotoxins. Next slide. Over 80% of Ontarians have one or more diseases or adverse health conditions. Since 2021, health disorders from all causes in all ages have increased by 20% above the mean average. The unborn and very young, the immune-compromised, and the elderly are at a huge risk of excessive fluoride accumulation, resulting in chronic health issues that worsen over time, and the creation of additional health and disease conditions. Immune-compromised people commonly have weakened and impaired liver and kidney functioning, preventing them from excreting fluoride efficiently. And this leads to worsening of all disease symptoms and creates additional health complications as time goes on. 70% of U.S. children have dental fluorosis, which also means their bones and pineal gland are compromised. In conclusion, Health Canada still stands by research done in 1942 and states that the benefits of preventing cavities outweigh any potential health concerns. September 2024, a U.S. federal judge ruled that water fluoridation poses an unreasonable risk of reduced IQ in children. And the U.S. recently announced that they advised to stop fluoridating all public water in 2025. Up-to-date scientific evidence shows that the risks of fluoridation outrank the ideology of prevents less cavities. I ask Hamilton Council to stop or pause water fluoridation immediately, citing the precautionary principle until safety concerns using recent data have been addressed. Thank you.
Okay, now that we're at the end of our delegation, it's just an activity now of receiving that delegation. I have a mover and seconder to receive the delegation. Moved by Councillor Huang, seconded by Councillor Kassar. And so that means that if there's any discussion, debate, questions, also just in case people would like to know, Senior Director of Water, Nick Winters, is in the room in case people had water-related questions they wanted to ask. I know, of course, our public health staff is also here in case people had questions they want to ask about the delegation or any comments people wanted to make. I'll just speak for another few seconds to allow there to be space for anyone who wanted to raise their hand. And alas, or alack, Tammy, please.
Thank you, Chair. I think the big question is, are these warranted, or is this delegation and the facts that she has delegated to us, are they true? Through you, Chair. To Dr. Liu, I think, because I think Dr. Richardson did one of these.
Yes, I don't know that we can have Dr. Liu respond to every single thing shared in the delegation, but in general, Dr. Liu, if you have a response that you can provide.
To the councillor through the chair, Brendan Liu, Associate Medical Officer of Health. So community water fluoridation continues to be held as a safe, cost-effective, very important public health measure in terms of reducing the risk of dental decay in children and adults. It continues to be held as a crowning public health achievement by organizations worldwide, including World Health Organization, dental associations, both nationally and internationally, and provides oral health benefits that are equitable across socioeconomic groups, particularly those who may have barriers to other forms of preventive dentistry. With any sort of substance, we're always considerate of what the health impacts of that substance may be, whether those are positive or protective effects, as well as those that may have adverse effects, and that with any substance, there always are thresholds that we're considerate of, that where health risks are a matter of concern that we would be wanting to avoid. And so we are in adherence and alignment with the Canadian drinking water standards around the levels of fluoride that are provided in drinking water to prevent against adverse effects as described in the current best available research evidence. This is monitored on a regular basis and is provided in such a way to maximize the health benefits, particularly related to dental decay, which we know is a significant health risk and concern, particularly amongst those with barriers to care or who may be marginalized or at higher risk of other negative health impacts related to health inequities.
Thanks. Councillor Huang, yep.
Just as a follow-up then, I appreciate that. Thank you, Dr. Liu. Do we necessarily need to have the set standard of fluoridification, or is this an opportunity for us to decrease it? Is that even recommended, or is that possible?
To the councillor through the chair. So the levels of fluoride in drinking water are monitored on a regular basis to maintain the meta level to be able to achieve the health benefits that are reaped through the provision of fluoride through drinking water, while being maintained well below a level where we would be concerned about negative health impacts related to fluoride, such as fluorosis, as has been described. The neurocognitive effects related to fluoride were also cited, and there is certainly evidence for neurocognitive effects at a high level of toxicity around fluoride, but this is not present or borne out in the current best available research evidence at the level through which fluoride is currently provided in drinking water, and that's a part of the careful monitoring of the levels provided, and as with any substance, maintaining that at a level that is protective to health and not detrimental in the way that we would be concerned at a toxic level.
Okay. Last question then through you, Chair, is to Director Winters. The delegate talked about fluoride in the water pipes and how it has a negative or adverse effect on the lead pipes that I know we do have a lot, but what is your, perhaps you can answer that particular question on fluoride in our system and how it might be corroding our system.
Certainly. Through the chair, Nick Winters, Director of the Hamilton Water Division. To the councillor's question, so fluoride, the chemical itself, is an oxidant, a very strong oxidant when it's concentrated, but at the levels that it is injected into the city's treated drinking water for protection of dental health, there's no concerns about oxidation of lead pipes related to the amount of fluoride that we have in the water. The delegate referenced the addition of orthophosphate to the city's drinking water as a protective measure against metals leaching into that drinking water. And that's a protection from other factors, hydrolysis. There's always some amount of metals that will interface with the water and leach. And so we're protecting against that type of interaction. It's not related to any impacts from fluoride.
Thank you. Those are all my questions, Chair.
Thanks, Councillor Huang. Appreciate those. Anyone else have questions or comments? Vice Chair Johnson.
I don't know if this is a comment or a question to Dr. Liu. A number of the citings and references that were given in the comprehensive presentation were American data, and I was wondering if you know when the judge made the ruling about that to protect children, how the American Academy of Pediatrics reacted as a large pediatric health body, how they responded, because that might give us some insight as to, a large, broad section of pediatricians reacting to that.
To the member through the chair, I'm not specifically aware of how the American Academy of Pediatrics has responded to this change. I can share that a recent Health Canada expert panel, having reviewed the most recent scientific evidence, has found that Fluorosis is the most specific outcome of concern when monitoring for levels of fluoride toxicity within the population, and that there is not sufficient evidence to support a causal link of fluorides having a negative impact on neurocognition below levels of 1.5 milligrams per liter. And that is consistent with a recent published report by the U.S. National Institute of Health National Toxicology Program around that endpoint of a threshold far higher than the level that's maintained as a supplement through drinking water.
And I think the response by both the American Academy and the Canadian Pediatrics Society was that it is a preventative health measure at a large, and just to highlight what you said, that it reaches a larger population that may not have access in other ways to preventative dental care.
Thanks. I don't see anybody else on my speakers list, but I'll look around in case anyone wants to raise their hand. Not seeing anyone? Okay, we're at that little formal part where we receive the presentation. All those in favor of receiving the presentation? Anyone opposed? Can't see anyone opposed. Okay, that carries. The presentation has been received for the record. We're on to 7.1, which is items for information. And so we're just going to receive individual parts of correspondence here. So can I have someone move in second that we receive the correspondence under 7.1? Councillor Huang, Member Danko. Any discussion on 7.1? Not seeing any. All those in favor of receiving 7.1? That's everyone. Thank you. Now we're on to 7.2, which is the second part of our Public Health Subcommittee orientation. And committee members will have Dr. Richardson come up to the podium to present. There'll be an overview of public health in Ontario as a first presentation, and then a second presentation to introduction to programs and services. Just want to say at the outset, I'm aware we have a new procedural bylaw in effect that says presentations can only be 10 minutes long. Since these are considered also training of some kind, we're going to let that go a little longer, and in future just to expect that if we see presentations from staff, those will usually only be about 10 minutes long, just so everyone knows. Whenever you're ready, Dr. Richardson, take it away. For those following what's happening next, at the end of this presentation, we'll simply receive and make comments on the report related to the presentation like we did at our last meeting, and then we have 2 motions to discuss before the end of today's meeting. For those who don't know, there'll be also a little get-together after this in room 192 for folks who want to get to meet members of the Public Health Subcommittee organized by the Hamilton Anti-Racism Resource Center. So just letting everyone know that.
Let's try that now. Yeah, that sounds like it's better. Okay, good morning, everybody, and a bit of a snowy morning. Hope everybody had a good weekend, a good month since we saw you last, a good holiday season, indeed, since we saw you last. So as the chair has referenced, this is the second in a 4-part series of orientation. And we're mindful of the time and the changes that are going on, but we do think that these matters in terms of providing a fulsome education is important to go a little bit longer than that current boundary. Today we have an overview of public health in Ontario, and so we have Loretta Ryan, who is the Executive Director of the Association of Local Public Health Agencies of Ontario, here, as well as Monica Turner. So Monica is a long-time public health person who's been more public health adjacent a little bit of late with AMO as well. So she has worked both within the Ministry of Health, but also with the Association of Municipalities of Ontario, and is now working independently and supporting some of the work that ALPH is doing. So they're going to go through that piece. The chair had talked about how getting to know the front row up there is important to do. And so that's a little bit about what the second part of this presentation is about. We have the directors who are here. Kevin, unfortunately, is not. He's taken ill this morning. And so I'll do his presentation piece in his place. But he's often the one that individuals interact with the most because of the nature of the work within healthy environments. So we'll go through and do that as the second part of the session. Just referencing again, at some point there will also be some education that's separate from this that clerks is arranging around conflicts of interest in that sort of piece. Just a couple of updates before they begin. One was just again to flag this piece about the More Convenient Care Act. That was the piece of correspondence that you just received. Part of that legislation did introduce the intention to move to a semi-autonomous Board of Health for Hamilton. And so we are awaiting to see how that moves through the process. It's been indicated it will go through the usual process, so it's been referred now to committee after a second reading, and there is a public consultation process which is open until January the 31st in terms of that legislation. I'm just looking, Matt, because this one's not moving at all. Sorry, it's just interesting to see between these two screens. Most programs, as well from a funding perspective, are cost shared for public health within Hamilton. And so we just wanted to draw that to your attention because it comes up during this presentation that Monica and Loretta are going to do. Our current funding ratio for Ontario Public Health Standards programs is 69-31. There's been a long history around funding. It is one of the issues that is currently being looked at as part of the renewal, which I'll get to in just a moment. The intention had been to restore to 2018 levels, which were notionally a 75-25 funding level, but as you can see, we're not there. Some municipalities, some boards of health are down in almost the 50-50 ratios, so we don't fare badly in comparison to them, but the municipality itself provides substantial dollars over and above the sort of cost share match that would otherwise be there. We do have a number of programs as well that are 100% funded either from the municipality, they've chosen to provide those over and above the standards, or we've attracted a federal program or a provincial program to operate here as well, and so there's examples of those on the screen. And the Strengthening Public Health Strategy, there are three legs to that strategy that have been rolling out over the last couple of years, it feels like now. One is to clarify roles and responsibilities, and so that is primarily looking at the Ontario Public Health Standards. We had thought they would come out with new standards by the end of last year, but as they went through the consultation process and have been worked through at the provincial level, we're now told to expect those in August of this year, so that'll be in time for us to renew our program plans according to those standards, and then to have them fully in place for January of next year. There have also been voluntary mergers. Several of our health units in Ontario were quite small and didn't have the size to have the expertise that is needed to do the public health practice of today. And so voluntary mergers were encouraged, and indeed in regulation changes that passed just before the holidays, there has been a merger of 9 health units into 4 new health units going forward, including some around us. And then lastly is the funding piece, which I've referenced has been another piece of the equation. And so the province is doing a review of the funding, that base funding methodology. There's been a little bit of movement on that we've heard about, but we don't know. Notionally, again, that was supposed to be in place for 2026, the changes, but we haven't really heard a timeline in relation to those elements. So just wanted to give you a little bit of that background, and now I'm just going to turn it over to Loretta and Monica. Take it away.
Thank you. Thank you so much. Thank you, Dr. Richardson. Thank you to the chair and to the board members and the wonderful staff, some of whom we had an opportunity to meet this morning. We're grateful to be here today. I'm Loretta Ryan. I'm the Chief Executive Officer at Alpha, and I'm just going to set the stage, and then I'm going to turn things over to Monica and hope this advances. Yes. So we don't have a lot of time today, so we're going to go rather quickly through some of the information. We are happy to answer questions at the end. You'll also see in your package an orientation piece on Alpha, and if you have any questions, we're happy to answer those too. So we'll talk about what is public health legislation in Ontario, Ontario Public Health Standards, and the accountability framework. We'll also talk about your roles and responsibilities, the Board of Health structures, Ministry of Health, a little bit more about public health funding, Alpha leadership and services. We're just going to touch more on the conference. I was just asked to also to talk about the symposium, so I'll give you the highlights of that. And again, any questions and answers that you have. And I will now, without making much noise,
pass this to Monica.
Thank you. Appreciate being here, and thank you for that. I will say I lived in Hamilton for 7 years. I went to McMaster, and I will also say that I started my public health political career when I worked at the Sex Ed Center at MAC in Hamilton Hall. That was way back when. It probably still doesn't exist, but I got involved in both public health and the Sex Ed Center, and then I joined the MSU when they started to cut our funding. Does it sound familiar? But thank you. So I'm going to talk about what is public health. You know a fair bit about this, but what I'm going to try and do is pull it together with the Ontario Public Health Standards, and as well, what as you as a committee need to be cognizant of. So you know that public health is the art and science of protecting and improving the health and well-being of people in the community. Very much focus on social determinants of health. The province is now looking at calling it the social and structural determinants of health. That was in the proposed revisions that came out in May. We'll see if they make it through when we get them in August. So they are changing that up. I do like the World Health Organization definition of public health, which says it refers to all organized measures to prevent disease, promote health, and prolong life among the population as a whole. Its activities aim to provide conditions in which people can be healthy and focus on the entire population, not on individual patients or diseases. And as you well know, it's preventative and tries to be upstream. And people really confuse that with the acute healthcare system, which is focused on individuals at the time that there are symptoms and there is disease. Public health tries to look at it from a population base. That may involve focusing on population, priority populations, because it's hard to do entire communities. And where can you focus, especially when resources are scarce? And there is some overlap between primary care and public health. They do similar interventions, but for different reasons and different focus. And in particular, sexual health and immunizations. Again, they're done for different reasons, but there is a good overlap. And again, public health always works well with primary care. And from an ethical perspective, though, people don't understand that public health looks at populations and not individuals from an ethical point of view as well. So I'll go to the next one. So the public health system in Canada, which many people do not understand because the province is the primary, has the primary responsibility for health. But the federal government obviously has a role as well. They have the Public Health Agency of Canada. They have the First Nation and Inuit Health Branch in Health Canada. But they also have the Canada Health Act, in which the whole the principles that govern the Canadian health insurance system reside, and that is universality, portability, accessibility within a public administration point of view. So that sort of guides the principles, but it is the province that is responsible, and I will not go into the BNA Act and the Constitution and all that good stuff, but it is the province. I will say that the province spends, well, last time we looked, less than 3% of their health budget is on public health. Which, again, when you're looking at upstream, we want more so that you don't have to deal with people in the acute care system, but that's not the way it rolls in the ministry. So in the Ministry of Health, which Loretta will talk about more, you have a chief medical officer of health, and you also have the Public Health Ontario, which was created out of the review of SARS and what we needed in Ontario, and I'll talk more about that. And as Dr. Richardson said, you have local public health agencies, health units, and we now have 29 health units, down from 34, and that was effective January 1st. I will also say the ministry thought that those boards should have meetings on January 1st. And they gave us 3 weeks notice. It was lots of fun. Public health legislation, and I always joke this can keep you awake at night If you need to keep up, there are some sections I'll tell you that you should look at. But the one you should really get to know, and I'll go into some details in the next slide, is the Health Protection and Promotion Act. It essentially, it's a good read. It tells you what public health does in Ontario. It also does get changed from time to time, and I'll flag that to you, but it's to provide for the organization and delivery of public health programs and services. Very specifically, I'll get to that, prevention of the spread of disease and health promotion and protection. But the thing is, a Board of Health is a local board under the Municipal Act. So you also have all the municipal aspects of legislation coming into play as well that you need to be mindful of. And you know as well as I do about meetings, closed meetings, all that interest, the fact that the municipal world is completely transparent as opposed to the provincial world, which is completely opaque. You're never invited to watch cabinet like you are even in a meeting like this. When I was at AMO, I asked one of our policy interns to count how many pieces of legislation affected municipal governments. It was over 280 pieces of provincial legislation that bear on municipal governments. So that gets us into a whole other conversation, but that you need to be at least mindful of that environment. And then things such as Municipal Freedom of Information and Protection of Privacy Act, MFIPA, and for the retention of records, you're dealing with personal health information. So you've got the Personal Health Information and Privacy Protection Act, PHIPA. I will say that legislation is over 30 years old. They're terrified to open it because of all those things, but it still talks about CD-ROMs as a method by holding data. And we know that technology changes, so we'll see if we ever get legislation changes for that. So just to say, boards of health are accountable for meeting all legislative requirements. So getting to the Health Protection and Promotion Act, or HPPA as we like to say it, it is very specific, especially Section 5 sets out the specific areas that must be provided by a Board of Health. And this includes community sanitation and the prevention or elimination of health hazards, provision of safe drinking water by small drinking water systems, control of infectious and reportable diseases, including providing immunization services to children and adults, health promotion, health protection and diseases and injury prevention, family health, collection and analysis of population data, and then any other additional programs or services as prescribed by regulation. Regulations are, again, provincial. So in Section 7, it grants to the Minister of Health, the ability to publish public health standards for the provision of mandatory programs. And mandatory programs are what they were called in 1998, and they are very specific. They're now the Ontario Public Health Standards. They're very specific about what public health must provide to the populations. You've got a number of other sections. They're out there. I won't read it. I'm conscious of time. But Part 6, which is health units and boards of health. That's key for boards of health. That sets out, again, a lot of specifics for you. It talks about the composition, operation, and authority of boards of health. It also gets into, and I'll come to this later, funding of obligated municipalities, a term that municipalities really dislikes, but that's what's in the legislation. And then Part 6.1 was put in 2009 after SARS and such, giving the Chief Medical Officer of Health specific powers that were needed during SARS, but were also then helpful during COVID. And then lots of administration as well. The Ontario Public Health Standards, and a little bit of history. As I said, in 1998, there were the mandatory programs. This was done at the same time that public health was downloaded to municipal governments. And when they downloaded it in legislation, and I'll get to some of those specifics, they made very, very, very detailed what you should do for public health in programs and services. I think even telling you how many community meetings you had to have in a particular subject. And I'm seeing Dr. Richardson nod. So yes, some of the history. So that was the download in '98. In 2008, there were the first Ontario Public Health Standards, and I will say it was my branch, and I was the director that got to do it in 2008, and it was a joyful 2-year adventure to do it. We did rewrite it. We also made it much less specific, and so that it could be specific to your particular populations. But it's also where the foundational standards came from. We had never had that before, but they were all elements of what was good public health. And so I always joke, it's sort of the other program standards rest on the foundational standards. I used to use the little statue of Atlas holding up the globe, and such as the metaphor for the foundational standards. So as Dr. Richardson said, they're revising them again. We'll see what they said. They were fairly extensive revisions that came out in May, and you'll get to see in August what they did with them. But I will just move on to the accountability framework, because you as a committee really need to understand what the boards of health are responsible for as you're giving them advice. I've got 2 slides on this. So you've got 4 domains, again, fairly specific. They're at the front end of they're midsection in the Ontario Public Health Standards. You might want to give them a review. But we were expecting new draft materials on accountability framework in fall of 2024 that were to go with the changes of the Ontario Public Health Standards. We haven't seen them, but there were some things from the accountability framework that were missing in the revision. So we'll see if they're there. The next slide, please. So again, I've laid out all the elements you have, and the annual service plan and budget submission, and that's usually due about March 31st. And again, these requirements, they will come to the committee, they'll come to the board. You're not responsible for doing them. Staff, of course, do that work, but you need to know what the boards need to review and such. So the annual service plan and budget submission, very detailed. It's 70 plus pages of very detailed, non-integrated framework. But it's where you get a lot of the information. But I will go, my favorite line is the last one, which is the boards of health must comply with all legal and statutory requirements, as if you had to be reminded of that again. Because between the legislation, the HPPA, the Ontario Public Health Standards, the accountability framework, there's lots of ministry oversight of Board of Health and Health Unit, finances, activities, and performance. In a lot of ways, public health is under a microscope of the ministry. You are accountable, or the boards of health are very much accountable. So I'll now stop and turn it over to Loretta.
Thank you, Monica. So a little bit more about your roles and responsibilities. The Board of Health, in your governance role, you're going to set the goals for your organization, and you're going to establish the systems and processes to support and achieve these goals. So very much a governance role. You do this by establishing general policies and procedures within the operation of the public health unit. As Monica mentioned, you have to uphold provincial legislation, the HPPA and others. You're accountable to the community for ensuring the health needs are addressed by the appropriate programs and ensuring the health unit is well managed. You ensure program quality and effectiveness and financial viability. You hire your medical officer of health with the approval of the Ministry of Health. You also assess the performance of the medical officer of health and the associate medical officer of health, which you also hire. And then you have to assess your own performance. It's a very important part of being a high-performing board is to assess yourself. There are critical elements of this for an effective health unit: principles of governance and board accountabilities, a statement of the board's obligations to act in the best interests of the health unit, the roles and responsibility of the board of directors, the roles and responsibilities of individual directors. For example, the chair would have specific roles. You need a clear differentiation between governance and management. And this is an area where some boards really struggle with, so it's important to know what is governance and what is operational. Board needs to be focused on strategic leadership and direction. It's a really, really important role. And the board establishes policies, makes decisions, and monitors performance of the organization's business and, as I noted earlier, its own effectiveness. Many of you wear many hats. I once had a picture of one of my board members for Alpha, and we put 7 hats on him, and we stopped because we ran out of room, but we knew that he had at least 7 hats. So juggling many hats can be very challenging. Monica's just going to make a note about a survey that she did.
Well, it wasn't so much a survey, but I interviewed 3 former Board of Health chairs, and all of whom worked for municipalities. One was a mayor, one was a regional chair, and one was a CAO who happened to be chair of a board of health. And I said, how do you manage the juggling of hats? Because when you're at the board table, the Board of Health table, you have a fiduciary responsibility to the board, which also causes the tension from the municipal part of your brain as you're going through it. And they all admitted that, and they, again, can talk about this for much longer than the chair would like me to, so I'll keep it really short. But it's all about the fiduciary responsibility and that tension between what the board of Health must do to set a budget that meets all the requirements, at the same time knowing that it's going to go to, in your case, the municipality to affirm that budget or modify it, or for other boards to take it to all the municipalities that have to pay. There's some boards of health that have like over 30 municipalities that are under that board. One of the comments that they made is that public health is not like any other municipal department, and what they meant by non-emergency department, because public health is 24/7, 365 days, and that you also have, it's not a zero-sum budget in the sense that you need to be able to prove to the ministry that you're meeting all your obligations that I've talked about. So again, it's a balancing act, but when you're at the board table, you're wearing that hat. When it goes to municipal council, that's the hat you wear at that time. I'll pass it back to Loretta.
Thank you, Monica. So for you elected officials, that is indeed an additional challenge. We also have citizen representatives on boards. These can be appointed by a municipality, and provincial appointees. These are done through an order in council. There's a process for it. The bullet there with regards to current challenges, it can take some time for these appointments to be approved. And it's a little bit surprising for boards sometimes. It really can take a while for these to be approved. There are different types of boards of health. I know we don't have a lot of time, so we're just going to do the broad categories. There's autonomous, they're separate from a municipality. There's the term obligated again. So you can have multiple obligated municipalities on a board of health. You may have provincial appointees, you may have citizen representatives. And there are variations out there. Chatham-Kent, for example, is one of them. You can have semi-autonomous or single tier. So a municipal council serves as the Board of Health and staff within a municipal structure. And semi-autonomous occurs when council appoints members to a separate board, but retains authority for budget and staffing approvals. Somebody new into public health, it's a lot to grapple with all these differences. And of course, there's regional. Regional council is the Board of Health with no citizen reps or provincial appointees. Staff within the administration of the regional government are who they rely upon. Oh, still me? Sorry.
Yeah, it's still you.
Still me.
I'd love to do the Ministry of Health.
So the Ministry of Health, one of the largest ministries, their org chart, I think is at about 6 point now to fit it on one page. You need a magnifying glass. The lead cabinet minister for all provincial matters is the Minister of Health, and that includes public health. Has the HPPA, the authority to publish OPHS, the standards, make regulations, make medical officer of health and associate medical officer of health appointments, provincial funding, and conduct public health unit assessments. The Chief Medical Officer of Health is currently Dr. Kieran Moore. He provides public health advice within and beyond provincial government and provides public health advice and direction to boards of health, medical officers of health, and to the public. The CMOH is appointed by the Ontario Legislature, and this is important to know, the CMOH is also an Assistant Deputy Minister within the Ministry of Health. The CMOH has specific powers under HPPA if of the opinion there is a risk to health. The Public Health Division sits within the Ministry of Health, and this is a division that oversees, manages, and works with local public health units. 5 branches that report to an executive lead, who then reports to the Chief Medical Officer of Health. I think only the Ministry of Finance is larger, but I'm not sure.
No, I don't think so, but anyways.
Okay.
Next slide is funding. And again, could talk forever about this because it's always the focus. Funding always causes tension. I will not talk forever on this, but just a brief history. As I said,
Sorry to interrupt, but if you could just move the microphone back to you.
Whoops, sorry, I usually can. Yeah.
No, it's okay, just share, sorry.
Yeah. In 1998, the provincial government downloaded public health to municipalities. They also downloaded land ambulance, but that's a separate topic. But that meant they changed the legislation. The HPPA says, Section 72, that municipalities must pay for public health 100%. That people sometimes forget. So they downloaded it, told municipalities to pay 100%, and I'm conscious of Dr. Sider. If I get it wrong, he'll tell me that I got it wrong. In 1999, it went to 50-50, but again, the province did it as a matter of policy. They've never changed that legislation. Municipalities are 100% responsible for the funding of public health. And so then after that situation, you had SARS, you had Walkerton. Unfortunately, public health has a boom and bust situation. So the provincial government at that time did something called Operation Health Protection, taking from all the inquiries what was the best thing they could do. This is when Public Health Ontario was set up and such. But they said that by 2007, they would go back to a nominal 75-25 funding, with the 25 being municipal governments to pay. They also said at that time they would pay for any 100% for any new programs they put in, such as at the time West Nile and such like that. It got fuzzy after that. Then, as Dr. Richardson said, they did say in the announcement, and it's there in August 23, that they would go back to the nominal 75-25. We haven't quite got there, and she's quite right. There are some regional governments that pay over 50% of the cost of public health. In fact, I believe Hamilton, Dr. Richardson gave you the averages. I believe Hamilton pays 34% of the budget from the numbers given. Next slide, please. So this is the one that I joked about. If you want to, wake up in the middle of the night, read this. And this is the Section 72. The obligated municipality shall pay. And it says the expenses of the Board of Health and the performance of its function and duties under the HPPA and other legislation. And again, that's why I set out all the other legislation you must be mindful of. But Section 76 says the minister may make grants for the purposes of this act on such conditions as he and she considers appropriate. So what I'll leave you with is municipalities must pay. It's a matter of policy if the province pays. I'll turn it back to Loretta.
On that sombering note, I wanted to respond to a question the chair asked earlier before we take general questions, to let you know that, yes, we do have a symposium coming up. It's online. It's February 12th to the 14th. Dr. Kieran Moore and others, including Sabine Matheson and John Paranak from Strategy Corp. And if you have not had the pleasure of hearing an update from them, if you want to know the latest at Queen's Park, they're absolutely fabulous in terms of updating our membership. We will have a merger update Public Health Ontario will be speaking. And we also have our strategic plan update. We've taken our strategic plan. It's now 1-year anniversary. It is a guiding document for the association. And we've done, I think, a lot of really great things using that plan over the last year. In the afternoon, for the Boards of Health section, we will also have an update from the Association of Municipalities of Ontario, better known as AMO, with regards to their new homelessness report that was released last week. And that will be specifically for Board of Health members. And we'll have a legal update from Alpha's legal counsel. So that's February 12th to the 14th. Registration launches on Wednesday. Registration is actually open now if you're really keen, but we'll be launching everything on Wednesday. You'll see both a newsletter and an email telling you that you can now sign up. And to hold the date for June 18th to the 20th, that's where we're meeting in person in Toronto. We'll be back at the Pantages Hotel. It was a very successful conference last year, and we're currently planning that, including a session with Mark Forget, a noted Indigenous leader who was highly rated last year, and our members asked to have him come back and speak. And with that, happy to answer any questions.
Sorry, this is the end of this section. I apologize. I looked ahead and thought there were more slides in this part. So we're at the end of this first section. So any questions? I see first Councillor Wang had her hand up, and then we'll go to others who may have questions.
Thank you for your presentation. I want to refer back to slide 20, where you talk about the current funding model and challenges, and there's a 1% growth funding over the next 3 calendar years as of 2024. So that 1% is, I know previously that has been accounted for, but how is this calculation when each municipality grows at different rates? Because our municipality is growing a lot faster than other municipalities, so I just wonder, do you have any insight into how that funding calculation is? Because 1% is just, it feels like a static 1% number across the board.
If I may, through the chair, to answer your question, there's different levels to this. So in many ways, the Ministry of Health is exceedingly proud of getting the 1% for multiple years, because getting that out of Treasury Board is amazing, because they do not like doing multiple year. 1% is so below inflation and such. So it does not even meet the current programs and services you have, even though it's for 3 years. Then you also have the new standards that are coming for 26, and you don't know if it will fit that way. Only those that are merging get additional over the 1%. So the ministry was mindful of all those issues, and for the last 10 years, it's been a nominal 75-25 kind of, but it's also been based on what the Board of Health actually asked for, and different Boards of Health asked for different amounts. So you're absolutely right. The rate for different health units was some asked for 0, some asked for, over 10%, normally in years. There was lots of advocacy from Alpha and public health units and medical officers of health asking for more. This is what Cabinet, in their wisdom, decided upon.
That is a very diplomatic answer. Thank you so much.
I try.
Yeah. Thank you. So as my follow-up question then, through your work at AMO, what were some perhaps insight that you might have on how we as a public health committee could do better advocacy at the different ministry levels? Because it's not just Ministry of Health that we're talking about right now, because we're also seeing that there's potentially a brand new Ministry of Mental Illness, mental health, and those sort of challenges. So it seems as though it's not all centralized within Ministry of Health. Now it looks like there will be other smaller ministries inside of other ministries. So
That, if I may, that's a very interesting question, and again, much longer conversation. The Ministry of Health is unlike any other ministry, and right now, mental health and addictions is a associate ministry underneath it. And if you hear that minister talk, he was never given the money or the staff support to do what he wanted to do. So they may split it off, but the Ministry of Health is not very good at working with others. Again, I'm trying to be diplomatic. They are so big and they live in a particular world. They are trying to be better about working with other ministries and such, but from an advocacy point of view, one, they hate that word advocacy. I will tell you that. I was not allowed to use it while I was in the ministry. And the province, and this is true of any, be it progressive conservatives, liberals, they all have very thin skin. They do not like to be criticized. So one of the things I learned at AMO was you thank them very much for what they've done and encourage them to do better and how you can show them to do that. And you can have very candid conversations about outcomes at the same time, and this gets us into the whole discussion of health funding and such. Hospitals and physician organizations do have good sway at the Ministry of Health, and I know I'm being recorded.
I'd just like to add, Alpha works quite closely with the Ontario Medical Association and the Association of Municipalities of Ontario. One of the pieces of advice that we've had from government relations experts to appeal to both the hearts and minds. So with public health, the return on investment, it's very difficult to have a healthy community and a healthy economy without a healthy community. They go hand in hand. So one of the successful approaches that we've had is saying this investment in public health, this is what happens when you have this. And it is a challenge because one person once said it's almost the value of nothing. We didn't have that outbreak. Nobody got food poisoning here because public health did its job. But we know from the pandemic, we have examples where we can clearly show the economic impact when you don't have a healthy population. So that's something that a lot of boards are looking at. How can you best position what your asks are? And that's within how are you supporting the community that you're serving? So it's a little bit of advice we were given.
Thank you. As follow-up, just to ED Ryan, I'm glad you brought up the economic impact of that. I know Alpha is being a small and mighty organization, but do you have capacity or resources to help us with understanding the economic impact of public health? Because I think about our homelessness and our homelessness strategy, our team works really hard at trying to identify what is the economic cost of homelessness. And I don't know if that's something that Alpha can help with. And so my question is more fundamental. Is that something that Alpha can do? Do you have a policy team that can help us with just breaking down the numbers? Because as you have just said, these ministries are very economic driven. And so they do listen with their hearts, but they calculate with their calculators a lot more strongly than they do. So.
Thank you. So this is where working quite closely with AMO comes into play. We do have a resolution with regards to homelessness. So supporting an organization such as AMO when they come out with this type of report, again, presenting it at the upcoming symposium, these are all part of the education and information that we do when we're supporting a partner. The other thing that we've been doing, and it's been highly effective, it will sound very simple, but it's worked really well at meetings at Queen's Park, we have infographics. And I'm happy to send in and share the link. One of the most recent ones was on the value of public health. We'll be continuing with these Public Health Matters infographics. People are really busy at Queen's Park, as you all are around this table. A big report is great for their staff. They will go through it, they will read it. But if we want to get the politicians' attention, we have found these infographics that have the stats similar to what you're talking about, graphically laid out, easy to read. We use that to start a meeting, to engage a conversation. They're not cure-alls. It's one page back and front, but they're highly effective communications tools. So those are on the Alpha website, right on the homepage, and look for more. And if you have ideas for ones that you'd like us to do, we're always happy to hear from the membership. A lot of what we do is a result of that feedback. Thank you.
Thank you. Those are all my questions, Chair.
Thank you. Okay, Member Kirkby and then Member Chung.
Okay. Hi, thanks so much for your presentation. My question is I'm just curious about the changes to the public health standards and the impact that might have locally on our public health approach here in Hamilton. So I'm just curious if you have any insights from what you know of the recommendations to date, if there's any major changes or things that might be good for us to have some insight into now, even though they're not coming until August, but just for this table to be aware of.
To you through the chair, I will say that we reviewed the revisions in May. A lot of things can happen between May and when they release them next August. I will say that the changes were, in my mind, subtle in the sense that they asked staff to do more things directly as opposed to consult and advise. It was in there doing the partnerships, which takes more staff effort. They also have more extensive protocols, especially saying relationships with Indigenous communities and organizations. There is more of a focus on the doing and the partnerships and following up with it. They also collapsed a few standards so that there's basically a comprehensive chronic disease that they put about 6 other standards, including school health in. So I think that's going to be, if they continue to do that, that's going to be very complex for public health units to work through how they can do those interconnections, because I have discovered over the years health units often follow what the standards are and use them as a guide for how they organize themselves. So we'll see what they say in August. They have given from August to January for implementation, but combined with the 1% budget increase at this point, it's, I think, challenging, and one of the issues will be where's your focus on priority populations, because you won't be able to do everything. That's just an observation.
Thanks, and on to Member Chung.
Yeah, thank you for your presentation. Just had a question in terms of mergers. So I know you guys presented a lot of mergers, and it seems like that's something the ministry is really trying to incentivize in some ways. It sounds like it's a phenomenon mostly for smaller boards and groups. Is there a phenomenon of that happening in bigger groups at all?
May I take this? I will say, yes, one of the issues, and it's been an issue for the ministry for over 20 years to merge smaller health units, especially in Northern Ontario, et cetera. They don't have the capacity, say, that Hamilton has. And one of the things that the ministry often does not say is that regional boards of health units and those that are within single-tier cities like yourselves are actually more efficient for the cost of them, because you don't have everything separate. You're integrated within a municipal structure. And so the marginal costs are much less. But no, usually there's been a lot of assessments over the years. Smaller health units they may have 1 EPI, they don't have 2. They may not have an associate medical officer of health, so that the MOH is 24/7, which just is exhausting. The smaller health units, they do the best they can, but it has been, the province has always looked, fewer is better. For multiple reasons, and they did learn from 2019 when they tried to force the amalgamations to only 10 health units in the budget. I don't know if people remember that. That was quite an interesting day. They said, yep, 10 health units, and it didn't go well. And municipalities really fought for their health units. But they are trying to get better capacity for surge capacity, for just being able to have a larger pool of people to do. So it has been something, I could cite the 2006 Capacity Review Committee, which again actually talked about many of the mergers that have now occurred.
Okay, I'm not seeing other speakers on our list. I'm just going to pass the chair to Vice Chair Johnson for a moment. Just wanted to clarify if you could give a little more information about where the Alpha conference is located. The hint on the internet seems to be it's on the internet because there's not a location provided, but I thought I would give you a chance to do so because at some point today we'll have an opportunity for people if they want to go to the Alpha Winter Symposium to declare their interest, and we can have a motion to that effect, and we can send up to 2 people to that symposium. So just ping everyone, think about that in the foregoing 30 minutes. But yeah, if you could tell us where it is located.
Thank you. Sorry if I was unclear. It's online. It's on a Zoom webinar platform. And we also have additional workshops at no extra cost that are included in your registration. One of them is with Tim Arnold from Leaders for Leaders. For those of you who have been at previous Alpha events, he is excellent at getting boards to work effectively together, highly rated by our members, so we're bringing Tim back. We also have a workshop, again, at no additional charge, with Esri Canada, and that's looking at geographic information systems and public health. The simplest way to explain this, it's sophisticated mapping where you layer. So let's say you're looking at flooding. You could do layer on layer on layer with all the different factors in. It's a very powerful public health tool. So that's a little bit more technical. So we'll have that as well. You don't have to attend everything. So you've got a workshop on the afternoon of the 12th, a workshop on the afternoon of the 13th, and then you have the symposium the morning of the 14th, and the Boards of Health section in the afternoon of the 14th. While we encourage people to take advantage of all of that, people have other things going on, so sometimes people will bop in and out. And lastly, because it's virtual, I won't be ruining anybody's Valentine's Day dinner.
Okay, thank you for that information. And everyone just keep in mind if you're interested in going, we'll get to that a bit later in the presentation. Yeah, go ahead, sorry.
Sorry, we've kept the price as well in recognition of the fact that everybody has very tight budgets. We have not increased the fee for the symposium for at least 2 years now. So we're trying to keep it as cost effective as possible, and we are adding workshops and more workshops on to make it as high value as possible.
Thanks very much. Just one moment here. I'm just going to return to my roadmap to make sure I get the procedures right as they're changed. So we've had the first presentation. Yeah, thank you, and thank you very much. Vice Chair Johnson has returned the chair to me. So taking it back, thank you. Is there no further discussion on the presentation? We'll just go on to the next presentation. Thank you very much.
Sorry,
you wanted to make another comment?
Did you want to know about the elections you mentioned earlier? Would you like me to say something about that for the Boards of Health?
If you don't mind just saying that information as correspondence closer to the
Sure,
time, then we
happy
can have
to.
it distributed to everybody and they can
It'll
find
come
it.
in the newsletter.
Okay, thank you so much. Thank you very much. All right, we're on to the second presentation now, and I believe it's Dr. Richardson is going to be delivering that presentation.
Thank you, Chair. I'm at least going to kick us off, and then my colleagues along the row are going to continue on. Matt's just going to, rather than have us all sort of traipse down to the front and traipse back and trip over each other, he's just going to present from there, and we'll just wait 1 second for him to get that up.
And we're just waiting for the presentation to load, and we'll take questions at the end of this presentation as well before we receive both, and then afterwards the report, and then after that, if people are interested in going to the Winter Symposium, we'll entertain that discussion as well at that time.
There we go. Thank you, Matt. So we wanted just again to give you a couple of additional little pieces that have come up through the course of Alpha's presentation. But the main point of this part of the presentation is just to go over those programs and services. You heard a reference to the standards and just talk about how that relates to how we're organized here in Hamilton. But just a couple of things to note. So Monica talked about the annual service plan and budget, and it coming back to this group, and she talked about how it is a large document. In fact, it can no longer be done in document format. It is only an electronic template, which the ministry provides to us. They have not yet provided us this year's template. Usually we get that towards the end of the previous year in order for us to populate and bring forward. And so we had planned to bring the ASPB on February 24th to the next committee meeting, and we stay at that higher strategic level, going through the main purpose and goals and the high-level summary of the budget. However, if we don't get the template soon, we're going to have to delay that to a future meeting, and they'll delay its due date as well as we go forward. So it's somewhere February, March. You should expect to see it then. The annual performance and accountability report. So we do that each second quarter of the year. So we bring back a whole slew of key performance indicators, some of which are required by the ministry of us, some of which we develop locally in response to the local priorities. And we bring that forward along with an annual report for the public that we are obligated to put out each year. And that will come usually in May or June. I think this year we're planning for May. And then an organizational risk management plan. And so this is not about sort of the risks to the public's health or emergency situations. This is about, as an organization, what are the key risks that we face, whether they're, are there challenges in recruiting public health nurses or public health inspectors? Are there challenges in terms of documentation standards? They're really more the organizational elements of how it's run. And so staff go through an overview and develop all the risks within a framework that was provided by the Auditor General for Ontario. And we report on the highest level of risk here, and we present an action plan to mitigate them and do a follow-up on the previous years and how well that we've done. Just a quick highlight on the next slide, just again at the context that you heard. And so just to contextualize it here in Hamilton, the sort of challenges that we face around the broad mandate that we have. Monica talked about the breadth of the Ontario Public Health Standards and how it's really challenging with the resources that we have. I mean, it's always this case that there is more to do than there are resources that are available. We're always, as a society, having to make choices around things. And it's very much the case when it comes to the Ontario Public Health Standards. And so deciding which components of those standards that are most key to do here in Hamilton is a lot of what our staff do as they go through the planning process. And that's why talking about priorities and why we were mentioning them in that first meeting about what they were in 24, how we're working forward in terms of what will be the priorities coming forward for 2025. We have had an increased demand on our services as well post-COVID. We know there's issues like mental health and substance use and their impacts in the community. There are various areas where there's been a higher demand. And so again, priorities are important. And one of the things that's key for us is increased workforce flexibility. And so Monica mentioned the boom and bust sort of environment that public health works in and the kinds of programming that we do. So whether that's not just pandemics, which was of course a more extreme example, but when we're talking about outbreaks that happen or particular cases of disease. For example, we've had increased number of measles cases, which we hadn't seen in years, and they require, sometimes up to 100 contacts to be followed. Well, we can't completely reorient our communicable disease control program because there's, another 64 communicable diseases they have to follow up on. And so we looked at how can we introduce some flexibility in our workforce so that they can help to meet those ebbs and flows that happen over time. So it's a much more cost-effective way of doing it, and it has our staff working to that broad scope and maintaining those competencies as they go forward. So Jen Vickers-Manson, our former Director of Healthy Families and Chief Nursing Officer, have been key in moving this forward, and we continue to do that today. This is also something that Chief Medical Officer of Health in their follow-up report from COVID, had really pointed to being very important for health units to be responsive as we go forward. So just wanted to point to those, and now we'll get to the organizational part. Matt, if you wouldn't mind the next org chart slide. This just lays out the 4 divisions we have within public health services and the Office of the Medical Officer of Health with myself, Dr. Liu, and Dr. Harvey, who is online today because he too is unwell today, so choosing to keep that to himself rather than risk it for the rest of us. But those 4 divisions are communicable disease control, which is headed by Jordan Walker, epidemiology and wellness, which is headed by Julie Prieto, healthy environments, which is headed by Kevin McDonald, and healthy families, which is headed by Bonnie King, who is helping us out in the interim while we look to recruit a new chief nursing officer and director. So each of the directors is just going to go through, give you a broad, high-level highlight of the key goals in their area and the work they do. There is a narrative that we've included in, as an example, a story. For those of us, we all relate better generally to stories rather than numbers and bullets. And so that is there as well. We won't go into those in details, but just to hit a few highlights within each of those areas. So with that, I'll turn it over to Jordan. And in case anybody's thinking they'll have to do Kevin's again, I will do Kevin's piece. So.
All right. So thank you, Elizabeth. So Jordan Walker, Director for the Communicable Disease Control Division with Hamilton's Public Health Services. And so broadly, the goals for the CDC division are to reduce the burden of communicable infectious diseases of public health significance, as well as reducing the burden of vaccine-preventable diseases through the promotion and administration of immunization and enforcement of the Immunization of School Pupils Act. As well, the division supports the management of inventory and distribution of all publicly funded vaccines to community healthcare providers. And finally, responsible for preparing for, responding to, and recovering from emergencies with public health impacts. As you see on this slide, our division is comprised of 5 program areas, which again, as Elizabeth mentioned, are described in greater detail in the appendices to the report. But at a high level, our 5 programs are the Emergency Response Program, which has a goal to ensure and support organizational readiness so that we are able to respond and recover, as well as to mitigate risks from significant threats to public health or disruptions to public health services. So not just threats to public health, but threats to our operations as well. We have our Infectious Diseases Program, which has a goal to prevent and reduce the spread of morbidity and mortality of infectious diseases, and this is achieved through such activities as health promotion, as well as case and contact management for diseases of public health significance, something that certainly I think folks would be very familiar with following the COVID pandemic. Prior to that, not as many folks I think were aware of the suite of diseases of public health significance and the amount of case and contact follow-up that goes into every time one of those cases is identified in our community, which public health units undertake. Also within the division is the Infection Prevention and Control and Outbreak Management Program, which also has a goal to control the spread of infectious diseases within our community. This is supported through activities such as the provision of outbreak management guidance to local institutions, such as long-term care homes, retirement homes, congregate living settings, as well as infection control inspections, routine infection control inspections, as well as infection control complaint response in settings such as licensed childcare settings and personal service settings such as tattoo shops or aesthetic services. We have our community vaccination and school clinics program, which has a goal to reduce the burden of vaccine-preventable disease through supporting vaccine knowledge and confidence in our community, as well as administration of some vaccines, in particular the grade 7 vaccines in our schools, our respiratory vaccine clinics, which support COVID and influenza, throughout the respiratory season, as well as catch-up clinics for individuals who are overdue on vaccination, primarily targeted to, with those clinics being primarily targeted to individuals who have barriers to accessing healthcare or accessing those vaccines through other channels. And lastly, within the division, we have our inventory management program, which has a goal to ensure the effective management and distribution of publicly funded vaccines so as to minimize wastage, promote safety, and ensure the efficacy of those vaccines. Next slide, please. And so as Elizabeth mentioned, I'm not going to go through this story in great detail. It is both attached to the presentation as well as to the appendices. But this is an example speaking to the public health response to a theoretical case of measles. I do want to highlight this is not a specific example of a real world case, but it is a very typical response to measles, and it does highlight the activities of the CDC division, those which we would undertake in response to reports of a disease of public health significance, again, so as to reduce that burden of illness within the community. Within the example, it speaks to the support and case follow-up that is provided to families and individuals infected with a disease of public health significance. It identifies the specific or the contact tracing efforts that would be undertaken within the community to help mitigate further spread. As Elizabeth mentioned, around the flexibility of resources within public health services and building that flexible workforce, it does speak to the, as is can often be the case within infectious disease or within the CDC division, the need to reprioritize resources both within the division or across programs within public health services to address time-sensitive community needs and operational pressures in the event of cases or outbreaks that require significant contact tracing or vaccination, as certainly would be the case for measles. And lastly, it speaks to working collaboratively within the division to support access to timely vaccinations for individuals identified as contacts, particularly for those, again, with barriers to accessing those vaccinations through other healthcare providers. Next slide, please. And with that, I believe I'll turn it over to Julie Prieto.
Good morning, everyone. Julie Prieto, Director of the Epidemiology and Wellness Division. So I'm going to just follow a similar format as Jordan did, just noting that, of course, there is further information and more details in the appendices. So the Epidemiology and Wellness Division goals include focusing on mental well-being, substance use prevention, harm reduction initiatives, and outreach and addiction services for vulnerable populations. Providing data, surveillance, and population health information to ensure programs are evidence-based and responsive to local needs, and supporting business operations and service delivery in compliance with legislative privacy, security, and records and information management requirements. And so you'll see there on the left are the 4 teams or 4 programs that are part of this division. The first is the Alcohol, Drugs, and Gambling Services and the Mental Health Street Outreach Program. And its overarching goal is to deliver integrated, inclusive, and accessible services to individuals in Hamilton who are facing mental health, addictions, and homelessness challenges. The data management program ensures business operations and service delivery comply with legislative privacy, security, and records and information management requirements. The epidemiology and evaluation program improves understanding of population health outcomes and inequities in Hamilton. And finally, the mental well-being and substance use program works to reduce the burden and harms associated with substance use and promote community mental health and well-being. And next slide, please. Thank you, Matt. So like Jordan indicated, these are fictional stories, but really do help you understand some of the work within this division. So this is a story that provides an example of addressing complex needs of unhoused individuals. As noted, AK first contacted public health through a street outreach worker. So street outreach workers meet people where they are at and help those who are experiencing homelessness, mental health issues, or substance abuse find support and resources. This story also demonstrates the importance of continuity of care, which fosters trusting relationships between staff and clients. Over time, this allows clients to share their story and seek support as needed. Clients are empowered to actively participate in prioritizing their issues and identify their most pressing concerns. This story also highlights the complexity of need for some of our most vulnerable individuals in Hamilton and the importance of addressing the social determinants of health to allow individuals to be as healthy as possible. Okay, and I think I'm now turning.
So I have the pleasure of going over the Healthy Environments Division. I did just want to note as well that in the packages that you have the presentation, but attached to the report, you also have another version of this that has as well the email addresses for contacts for people and these descriptions about the programs and services within them. So just to make sure you have those there, those might be something to sort of keep on hand, set aside as something that might be helpful to you if you have questions that you want to relate to directors and staff in the future. So Kevin's area, Healthy Environments Division, it has 4 broad areas of programming. So chronic disease prevention, food and water safety, and health hazards and vector-borne diseases, as well as tobacco control. The divisional goals are to reduce the burden of chronic diseases of public health importance. And so again, back to that piece about prioritizing, needing to look at those that have the greatest burden in our particular area, but also looking at those where there's something that a public health strategy can make a difference with. So they have to be evidence-based from that standpoint. Promoting the development of healthy built and natural environments and mitigating the impacts of climate change on human health. And so we often talk here as well about air quality and how it fits in with both of those in that broader area. and then reducing human exposure to health hazards and to vector-borne diseases. And I'm going to give you a little bit more description of those programs in just a minute to really talk about the breadth of what some of these programs have to address. And preventing and reducing the burden of foodborne illness as well as waterborne illness. So again, looking at those program areas, the chronic disease prevention program currently is looking at 4 main areas of work. So one is around active transportation. And so if you change the slides, if you would, Matt, you'll see the story speaks to creating safe environments for kids in terms of getting to school and how important active transportation is there. And through healthy public policy. And so a lot of the work that is done within the chronic disease group is not done alone. It is done in combination with others. We had Nick Winters here who was talking about fluoride, to talk about fluoride and water issues, but we also work with our colleagues in planning, our colleagues in transportation, around these issues to try and move forward with a coordinated approach across the city. Reducing sedentary behavior in workplaces and schools is also a big focus area for the chronic disease program. Increasing accessibility and availability of healthy foods is another area, and increasing food literacy, particularly in terms of newcomers and working with newcomers to understand the options that may be available here and how they relate to traditional foods and cooking they may have done. Under the Food and Water Safety Program, it is a little bit more of the more straightforward one in terms of the description, kind of tells you what it is. They do inspections of food premises, festivals, and special events. They investigate food safety related complaints. And so if there's a complaint about a restaurant or an event, they would be the ones that those would go to. And they do training and education of food handlers and the public on safe food handling practices. So for example, we try to do something in the spring before the barbecue season starts out in order to prevent the general increase in related foodborne illness that we tend to see. They're also focusing on preventing or reducing the burden of waterborne illness. We inspect small drinking water systems. We also work together with our colleagues, Nick Winter and his colleagues, on issues that may arise within the city's drinking water system. We inspect recreational water, so everything from beaches to pools to hot tubs, all of those. And we complete annual mandatory inspections and complaint-based inspections on a frequency for each of those that is determined by the province. In the Health Hazards and Vector-Borne Disease Program, a very broad number of issues fall there. It makes it a bit challenging for that group because of the breadth of things that they need to address, but they're looking to reduce exposure to environmental health hazards and mitigate risks related to those. They do the work around air pollution and those exposures, and they also do the work around climate change as it relates to environmental health and climate change. They are the group that does our work on vector-borne diseases. So this really started for us with rabies would have been the smallest number of diseases we had originally, which then expanded really to West Nile virus. And then has continued to expand as the number of vectors of significance have increased. So other mosquitoes, other diseases that are changing in terms of where they exist in North America because of climate change. And so this group continues to do the monitoring and control related to West Nile. They do the investigation of rabies cases or any bites that might occur with dogs in our community, and they do surveillance for ticks, for Lyme disease, and other vector-borne diseases as they emerge. Our tobacco control program, has been a long-standing program of very important to our community and its well-being because of the impacts that tobacco has had on our population. They work to prevent the initiation of smoking and vaping through prevention campaigns, cessation counseling and supports, training health providers and social services providers. They also do the enforcement of both provincial and local bylaws as they relate to tobacco and vaping. They inspect hospitals and schools in terms of the application of the provincial legislation to those two sorts of institutions, and of course investigate complaints as well. They also go to corner stores and anywhere that sells tobacco to do inspections to ensure that they're compliant with issues related to youth access and product display. So a lot of work continues to go on, and tobacco is an important area of practice there. So I think, Bonnie, you're the one that's representing.
Thank you. Good morning, everyone. I'm Bonnie King, and I'm happy to be here as the Interim Director of the Healthy Families Division and our Chief Nursing Officer. The overarching goal of the Healthy Families Division is to support individuals and families across the city to be able to achieve optimal health before and during pregnancy, at birth and during the transition to parenting, and to support healthy growth and development through infancy, the early years, throughout childhood and adolescence. And of course, this includes focusing on parental health and well-being and family health and well-being. Our division also supports public health programs to meet the needs of priority populations and to decrease inequities while enhancing effectiveness and impact of public health services. And the Chief Nursing Officer role is to support the achievement of a consistent, high standard of nursing practice, as Elizabeth mentioned earlier, to its fullest scope by ensuring all nurses are practicing according to the relevant standards of practice. And there's 3 different standards in terms of the Canadian Community Health Nursing Standards of Practice, our Public Health Nursing Discipline-Specific Competencies, and of course, the College of Nurses of Ontario. As you see in this slide, the Healthy Families Division is made up of 6 different programs, each with its own specific goals and with a range of strategies and services that are described in much more detail in Appendix A. So for child and adolescent is the first one listed, and its goal is to improve the mental health of infants, children, youth, and their families by increasing access to mental health services, especially among priority populations. Our dental and vision screening program has several goals. First is really focusing on improving oral health among children through elementary school screening for students and providing access to the Healthy Smiles Ontario program, as well as ensuring the provision of vision screening in schools for students in senior kindergarten and linking with supports. And third, to improve the oral health among adults and seniors in our community that are experiencing low income and challenges in accessing insured services. The goal of our Healthy Growth and Development Program is to make sure all individuals who are pregnant and those with an infant or children under 6 and their families are able to attain and sustain lifelong optimal health and developmental potential. We do that through a wide range of services listed in the appendix. Our health promotion program supports evidence-informed programming and effective service provision across our division. And the planning and competency development program provides high-quality supports to enhance organizational effectiveness, efficiencies, and impact of programs and services. And of course, lastly, our school program works to achieve optimal health of school-age children and youth through strong partnerships and collaboration with our school boards and schools across the city. Next slide. So this slide is an example of how our Healthy Families Division can support families as their children grow. In this scenario, a parent is easily able to initiate supports through our phone line and get connected with a range of services in response to her needs. And then, of course, once her child's in school, there's access to initiate supports for dental health concerns and later easy access to brief counseling services through child and adolescent services. This scenario demonstrates our commitment to making it as easy as possible for individuals, families, and service providers to connect with public health and community-based programs and services by providing a variety of ways and many opportunities to access information, programs, and services. We work to ensure individuals and families are able to get connected with the right supports at the right time, whether it's through public health or through community-based supports and services. And we work to identify and understand and address barriers to healthy growth and development in collaboration with individuals, families, and community service providers.
Just get that back on. So that concludes this this part of the presentation. Happy to take any questions. Just a reminder in terms of where we're at. We've now completed our second session and have our next piece, which will be focused around the annual service plan and budget. We are going to provide a little bit of an overview of the Community Health Status Report that was received actually by the Public Health Committee back in November. We're just deliberating in order to meet that timeline or the timelines that are set out. We're thinking that it might be helpful to provide that in advance through a communication update And then we'll hit the highlights as we talk about the annual service plan. And so everybody would have access to it through that route and could ask any questions when it comes up as part of the annual service plan. And of course, that is going to have the renewed priorities for 2025 and the action plans that have been developed, as well as some financial information. On the last session, we are just working through exactly when to provide that with the presenter, just needing some flexibility in that piece. And so we'll see exactly when that piece ends up coming through. You'll begin to see shortly, you've had a lot of orientation materials these last 2 meetings, you'll begin to see shortly a number of actual programmatic reports which will get into the actual issues at play, if you will, as we start to go into February. So that's it for me. Chair, any questions? I'd be happy to have them and field them with the team.
Okay, I'll look around to see folks who want to ask questions. Member Joseph, you're first.
Hello, thank you for those presentations. I know in reference to the HPPA, it outlines a number of mandatory programs and services. And the first one around community sanitation and the maintenance of sanitary conditions. I know I saw the part around elimination of health hazards, but I was wondering where the community sanitation and the maintenance of sanitary conditions obligations under the Board of Health reside in terms of the programming, or if there is a gap there in need of action of a body like this, or this is a more than double-barreled question, but, and also if there's any epidemiological requirements for operationalizing that obligation under the Act.
Through the chair, so the general provisions that are there in the HPPA under Section 5, they reflect wording that was developed many, many years ago. And so the Health Protection Promotion Act was redeveloped from the Public Health Act back in 1983. And so the programs and standards that are then published outline the specific responsibilities within each of those areas that are expected by the provincial government for health units to do. So most of that work falls within environmental health in terms of food premises, water, wastewater, and sort of thoughts around those things and any other specific health hazards that arise. For example, during flooding, we're involved very much alongside our colleagues around what are the issues that arise in a home or business that has been flooded, issues around mold, issues around about safety related to those and providing advice. So it's not general broad community sanitation that generally rests with our colleagues over in Public Works, but it's the specific areas that are outlined within the Ontario Public Health Standards that are in that environmental health section.
If I can just follow up. Yeah, okay. I understand the ways it's operationalized. I believe we also have an obligation under the Act via the obligations to collect and analyze epidemiological data to assess local risks. And that may be a need. We could take a particular example of those living outside and conversations around community sanitation and the obligations of the Board of Health outside of Public Works to both assess and maybe address any needs that might be identified. So my query was, do those analytical projects occur where, or is it just, as you said, top-down kind of outlined via the Ontario standards?
Through the chair. So, as I noted, in terms of the areas of practice that are carried out, it is limited to the areas that are outlined in the standards that we currently have. Again, coming back to the issue of the evolution of practice and, what has happened to public health over time in terms of where that practice is expected and where we're directed to do the work and the issues of resources. that's where the resources also flow with the areas of practice that are currently expected of us.
That's helpful. Thank you.
Next up is Member Danko.
Thank you, and through the chair, thank you for the presentation. A lot of helpful details. I have two questions. The first is around the role of public health supporting access to mental health supports, and I'm thinking as opposed to the mental health street outreach, which is, a sort of a targeted outreach to very vulnerable populations. Does public health have any role in helping provide access or supporting access for, say, youth, noting that it is actually quite challenging sometimes to get access to a social worker? It's often not provided through primary care teams, and it's something that I hear about in the community.
Through the chair. So mental health is one of the challenges that we have in terms of defining roles, and then there being gaps in systems in terms of addressing it. And there's great awareness of those, both the challenges and the gaps that are there. And so from a public health perspective, our work is generally upstream. And so when you hear Bonnie talk about in Healthy Families, the work that we're doing from a prevention standpoint in terms of kids' early development around adverse childhood events, in terms of the work that they're doing in schools to support healthy school environments, bullying prevention, different things that have been done over time. Generally, we're on that preventive end of the spectrum. The exception for us here in Hamilton is that this council does also provide alcohol, drug, and gambling services, which are adult-focused generally, and also child and adolescent services, which is a children's mental health program. So those aren't, public health programs in the general term, but they fall under public health here. And so when it comes to accessing services, our child and adolescent program does work with other children's mental health providers to look at how can access be expanded. They have been doing more and more work in the community, going out to places like libraries and other locations so that they are there, providing more and more drop-in opportunities so that there is increased availability of resources to get on short notice. And they've been very successful with that work. It's been very good work that's been led by Lynn Foy, the manager of that program. But overall, there still remains a significant challenge when it comes to the gaps at a community level. The Children's Mental Health System is coordinated by Linwood Charlton Center, and so they have that overall responsibility for it. There's an awareness as well in terms of the transition point between children and childhood and adulthood, and sort of looking at how can that be well coordinated, and so the Greater Hamilton Health Network gets involved at that point. But it's in all of mental health. Could use, continued investment of resources and looking at how can coordination and the amount of supports and resources, treatment resources that are available be improved. Bonnie, did you want to add anything?
I think just emphasizing the access issues that we're really focusing on, and having child and adolescent therapists, Elizabeth mentioned in communities, but we're really trying to focus on areas that make it super easy for youth to just walk in and have a session with a therapist. And sometimes that's enough. Sometimes just having that single session and to establish a plan is enough to kind of get them through. And sometimes it's enough to get them through while they're waiting for services. So I think that shift to really community-based quick access is really helping, but there's lots of ongoing conversation across the sector about how we can continue to provide more services and in a more timely way.
Thank you for that. My other question focuses in on the specific focus on dealing with tobacco use and sort of prevention and whatnot. I was wondering if there's any role for public health, in terms of prevention enforcement around cannabis.
So there is a role for public health around prevention related to cannabis. For that, I'm going to turn it over to Julie and go from there.
Thank you, and through you, Chair. So through the Mental Wellbeing and Substance Use Program, we do have some ongoing work around promotion and prevention. And so we're just beginning actually that work and certainly can provide some more information in the coming months. But really looking at the educational piece, that knowledge translation, and ensuring that there is an understanding around the risks associated with cannabis use, particularly for youth.
Thank you very much, Member Danko, and thanks to the staff for answering those questions. I don't see anybody else on our list. Oh, Councillor Huang, welcome to the list. You're up next.
Thank you. Thank you for this presentation. As this presentation is open to the public and transparent because of how the nature of our committee meetings are, I kind of wish there was a slide that showed the greater ecosystem of public health because just as Dr. Richardson had mentioned, the Greater Health Hamilton Network, I almost wish that the public could really understand how interconnected the entire system is and how closely tied the public health team connects in with other resources like GIN, like the hospital network, like some. So I kind of wish that there was a slide that kind of showed how interconnected and extensive, because that's also how we recruited the public health committee members to be on this committee. So I think that there's a narrative piece that we're missing here with how we are integrated into the community. And I wonder, through you, Chair, if that could be a communications piece later on. So then that way, again, it's in public record. It just goes to show how well we're collaborating with each other.
Sure, and I guess staff can just take that away and maybe in our future training sessions could bring that in as a slide or two, or some other public communication. I see nodding, so they'll be able to speak to that in a future session. Thanks, Councillor Hoying. Anybody else who want to speak to the presentation, second part? Okay, I'm not seeing anyone, so at this point, I need a mover and seconder to put the report on the floor, and the report is just about the presentation. See Member Lennox and Member Danko. This is that moment, though, we're going to take any enthusiasm for attending the Alpha Winter Symposium from February 12th to 14th online. If anyone wants to go, this is the moment we'd have to record that because we don't meet again until after the symposium. So this is it. Okay, Dr. Joseph, are you interested in attending? Okay. Anyone else? All right, I'll also attend, just so we have some representation from Chair and Vice Chair in case there's something to report back formally. So happy to also go. So we need someone to move that, preferably not myself or Dr. Joseph. Councillor Huang, thank you very much. We'll move that, and seconded by Councillor Taddison. And the motion, which clerks will just housekeep afterwards, is that there'll be 2 people sent. Registration costs will be paid for by the city, that kind of thing. We do this fairly routinely, so we have some routine language just not in front of me at the moment. So if everybody understands the intention of what we're about to do, moved by Councillor Huang, seconded by Councillor Taddison, that we're going to send myself and Dr. Joseph to the Alpha Winter Symposium from February 12th to 14th. All those in favor? Great. And now we're going to have, and that's going to be an amendment to the report. We're going to have a little piece on the report there. I checked in with the LC and they checked in with the deputy clerk, and that's how we're going to do this. And so now we're going to, I suppose, approve the report as amended, but I'll look to the clerk in case I've made a mistake there.
Sorry. Through the chair, it wouldn't be amendment, it would just be adding a clause.
Okay, great. So we all understand that we're amending it by adding a clause. That's part of the activity that we just approved. Wonderful. So I need all those in favor of receiving the presentation, report as amended, and the communication item. That's everybody. It carries. And so we're on to motions today. So we have 2 motions, 9.1 and 9.2. And we'll start with 9.1. If Member Joseph could introduce the motion and your seconder. If you don't have a seconder, I'm happy to second. But otherwise, the floor is yours.
Thank you. I had raised this at our last meeting, and I appreciated the presentation and during the orientation session, the first one, around equity, and we had the opportunity to discuss some of it, and I shared my perspectives on how we got here. And very often, you know, when we think about health policy in terms of health equity, and as we broadly, big we, have been learning about how to address disparities and inequities by acknowledging that systems and structures, including governance structures, are complicit with the reproduction of inequities. That fidelity and integrity include the ways we are coherent in structure and form and discipline and policy and practice. I think we've done a lot of that work. I think this is a 7-word amendment to terms of reference that had been created before we've met. I believe that it does more to create a team that can do things together where everyone can see themselves as equally valid, equally responsive as necessary, that we're not all the same, that we all bring our own unique experiences and strengths, and those come from different histories. And the ways we reflect that in a structure, in a document, such as the terms through governance, allows for us to see each other as all possible leaders in this. In a practical sense, you know, we can operationalize how we do this as we see fit. I'm not asking for another vote here. I'm asking for us to do the other piece of the work that sees the change in the document itself, such that the structure reflects the fidelity to and integrity of the equity principles that we profess to have and share. So with that, do I read it? No. I'm moving that we amend the Public Health Subcommittee's terms of reference such that we add these 7 words to the part around the chair of the Public Health Subcommittee shall be a member of City Council, a community representative, or an educational representative, that both are possible.
Okay, thank you very much. Any speakers on this motion? I've added myself to the list, but I'll go last as the tradition dictates. Member Danko.
Thank you, and thank you to the mover for bringing this forward. I just want to check in to see if there are any unintended consequences of a change of this nature. In particular, I'm thinking about the chair of the committee or the subcommittee is often the spokesperson. During COVID, I can tell you that when you're the spokesperson for an entity, an organization, you do receive threats of lawsuits. And so these can be sensitive matters. Would the community representative or the education representative have the same legal coverage or support that a city councillor does, noting that city councillors are employed through the City of Hamilton, and the rest of us are here in a voluntary capacity? Thank you.
That's a fair legal question. I'm not sure we have legal staff here to answer that question, unfortunately. I'm just having a brief gander here, gandering more, seeing no one with a shaking head in the affirmative. Certainly something that could be raised in time for council, depending on what happens here anyways, because council would obviously rise as the Board of Health. So perhaps that's a question that you, if you don't mind, Member Danko is sending that question to the clerks, and then they can appropriately find a legal person. And if we can just remark on that at council, whether it's a concern or not. I don't know the answer to the question. I'm not going to opine on it. So we'll leave it there, unless there's another question that you had. Okay, before we go to second-time speakers, I'm just going to pass the chair to Vice Chair Johnson just to, oh, you want to ask something? Go ahead, please. So go ahead, go before me, please. Yep.
Just to follow up with what Member Danko said, my question would be, why would the protections be any different as a member of the subcommittee in comparison to the chair? Because if I was to speak or make comment publicly like I am right now, I'm taking a similar risk, I would imagine, that one has as the chair. So that's what are my protections the same? Would be what I would want to also know in addition to that. And how does that change or not change if I'm the chair? Because I don't In my mind, I can't, but not as a lawyer. But I just wonder about that.
Yeah, fair. We can add that nuance to the questions we're going to ask our legal staff. I mean, obviously, as the vice chair, you would sometimes take over the chair as you've done during this meeting. So I'm assuming those legal protections would apply because you are a citizen, but don't want to make any kinds of assumptions about that because we don't have anyone in the legal team here to answer the question. So I'm not going to, as a non-lawyer, just the chair of this committee, not going to opine on that. Any folks want to be added for a first-time speaker before I go? Looking down, not seeing it. All right, I'll pass the chair over to you, Vice Chair Johnson. Thank you so much. Be careful while you're there. Yeah. Thank you very much for this motion. I really appreciate it. And just wanted to briefly apologize. I think it was my misunderstanding originally that thought we had to have the chair be a member of council because of the way procedural bylaw was written, but I misread it. And so we can have either a citizen, the educational representative, or the a member of council be the chair. Happy for that to be the case. Happy to be here as long as people want me to be. The process works that I have to step down. So if anybody really wants to be the chair of this committee after a period of time, or if they're feeling comfortable or whatever they want to do, just come approach me about it. Because the way council sets it up is, if you are a chair of a subcommittee, you're the chair for the whole term. It's the only time that an election gets triggered is if someone steps down. So just being open about it, right? I don't have an overwhelming desire to chair this over other people who may wish to do that work and want to share that if people want to do it. And appreciate this idea that we don't want to wait until that moment to then try and change the terms of reference because it would politicize those terms of reference. So doing it now in a depolitical way, just by saying, hey, we ought to have this open situation here, makes everybody, I think, come into this from a more equitable perspective. So I just really appreciate the motion being brought. And those are my comments. So I'll take the chair back. Thank you. And does anyone want to speak for a second time before we vote? I'm not seeing second time speakers. So all those in favor of the motion? Anyone opposed? And we'll get that question answered before council deliberates on it. Moving on to 9.2, and this is the feasibility of implementing wastewater surveillance. This is a motion moved by Member Lennox, seconded by me. And please introduce your motion, and then we'll have discussion about it. And you don't have to read the motion out loud and all the whereases and things like that. You can just speak to it however which way you want. It's on the agenda and everyone has a copy.
Perfect. Thank you, Chair. Okay, so I'm going to speak to the motion where I'm asking for public health to look at the feasibility of implementing wastewater surveillance testing. I'm sure many are aware around this table, but the concept of wastewater surveillance has been around for many, many years, and it was actually used as sort of one of the main means of sort of addressing sort of the polio eradication campaign in many, many places across the globe. So this is sort of a process of surveillance and technology that has existed for many times and is used for many purposes. I think many of us became perhaps more familiar with wastewater surveillance through the Wastewater Surveillance Initiative that was launched in 2020 to address the COVID-19 pandemic. And so through that program, wastewater surveillance was initiated in many different places across Ontario that was funded through the Ministry of Parks. As part of that initiative, there were researchers at McMaster that were contracted by the province to assist with this, and so the necessary infrastructure is already in place in sort of our wastewater testing plants in Hamilton, and the researchers at McMaster continue to use these samples now solely for research purposes that previously were in place for public health purposes. But due to the termination of the provincial funding in July 2024, the infrastructure and capability is currently underused. The estimated cost of running this program, just so everyone knows, is annually fairly low, so estimated about $100,000 per year, with modifications based on the number of pathogens that you wish to test for and how frequently you're testing the sites. And one of the benefits of the wastewater sampling is that it's a really, really cost-effective tool for public health concerns. It can be tailored to identify specific pathogens of concern based on what a local community actually identifies as their priorities. So it can look at anything from respiratory viruses to sexually transmitted infections, for example, just to give you an idea of the broadness of the scope. And with the data sort of rapidly available, so usually available within 24 hours of testing, public health decision makers can mount an informed response and mobilize resources much more rapidly to address emerging concerns than if you were using medically attended case data, which is currently our mainstay. And we can even use this data to sort of narrow in on specific areas of higher concern. So during the COVID pandemic, for example, wastewater testing targeted at specific high-risk sites like long-term care were able to address outbreaks in specific high-risk settings in a way more effective, again, than case data. But despite this kind of established value of wastewater surveillance and the existing technology, most public health units are now still relying on heavily relying on medically attended case data. And there's a number of issues with medically attended case data. I think most of us would be able to sort of generate them based on sort of our experience and what we know in the community, but essentially, to identify kind of medical cases, you need someone to actually present to healthcare in some capacity. So that means that mild cases are most often missed because people don't present to any medical care. This often allows disease to sort of spread unseen and unchecked because we don't know that mild cases are occurring in the community. We also know that cases can only be diagnosed if they're considered. So speaking as a healthcare provider, I'm only going to test for something if I'm actually considering it on my differential diagnosis. And so for novel pathogens, things that we weren't maybe trained to see or have seen much in practice, those can be missed. Examples being things like Mpox, which was not something that most practitioners in Hamilton would probably have had to see very frequently, but that we did see emerging in the last couple of years that challenged clinicians. And also, in order for something to be tested or diagnosed, someone first has to then seek medical care. That requires someone to have access to medical care, and so we're likely going to see underdiagnosis among those who have barriers to accessing traditional health care, primary care, et cetera. And then when we look at other reference measures like hospital and ICU admissions and deaths, those are all really time-lagged measures that often present only when things have sort of already started to get more severe and things have been circulating in the community for some time unnoticed. And there was one just recent example of sort of the superiority of wastewater testing to clinically reported cases in Hamilton, and that was in 2023. Dr. Brendan Liu sent out an advisory to healthcare providers in Hamilton, letting them know that there were wastewater signals of Mpox that were outpacing the clinically diagnosed cases, indicating that we were missing something in the community, and we wouldn't have known that had we not had that wastewater surveillance data at that time. So, I think there's a lot of evidence for moving away from medically attended case data to sort of the more cost-efficient and effective methods like wastewater surveillance. We also know that, this is a core tool for any pandemic preparedness in the future, and I think it would be nice to think that we learned something from the last few years in terms of how to be better prepared the next time around. And as we're a public health subcommittee, I feel like preparedness and prevention is a key tenet of our work, and it would be wonderful to see all of the tools at our disposal being appropriately used. There are public health units in Peterborough and Ottawa who have recognized the value of these programs and have continued to fund them after the provincial funding ended. And so this motion really urges us to sort of look at opportunities and feasibility of doing the same in Hamilton. And I won't read the whole motion, but thank you.
Thanks very much. I'll add myself to the speakers list. Anybody else want to speak to this before we get there? Councillor Huang. Anyone else? Okay, take it away, Councillor Huang.
Thank you. I'm highly supportive of this motion. Just a question on what are we getting in the report back? Because as it says, it's the outlining of feasibility of implementing. So the question, and I don't think it's going to Dr. Lennox, I think it might go to staff, because I want to understand what is the timeline for receiving this report? What are the expected sort of outcomes that you would like to show us in this report? Because I think that, just as Dr. Lennox very eloquently talked about, there are so many different things we can be testing for. So what would be the operational efficiencies on what is, we can't obviously test for every single possible thing. So what is the expectation for something like this? And then also, I do recall that Dr. Lennox talked about it's approximately 100,000, but I don't understand what that 100,000 paid for. So does that mean that we need to have a full-on another lab technician in wastewater to be able to do this work? Because I know that, putting on my other council hat, wastewater is going to be adding a lab technician to their FTE count. So would something like this require a second lab technician? Would it need a totally different lab setup? Would it, like, that's what I'd like to understand in the feasibility of implementing. I don't know what's involved in the report.
Thanks. Without opining on any of the questions Councillor Huang asked about the specifics that would be forthcoming in the report, does anybody want to speak to what they understand the motion to be asking for, and if it addresses the questions Councillor Huang had asked about?
To the councillor through the chair. So I think that a number of those elements as you described could certainly have additional information provided by staff through the COVID-19 pandemic, where we had access to wastewater information that was testing that was not performed in-house by public health staff. That was data that was tested at a university laboratory. We actually did leverage the University of Ottawa laboratory through that process, and that was one of the labs that did perform much of the wastewater testing for many other locations across the province. And so the aspects such as the cost and those elements are unknown to staff at this point, as we've never been in a position to put out a request for proposal or any of the types of considerations around cost and resource intensivity of that, as we were participating in a larger provincial program at that time. So the feasibility would certainly include perhaps some information about should such a program be implemented, details such as who might be able to perform it, what the cost of it might be, what the process for procurement for such a solution might be, and those would be some of the things that I think that we would interpret within the wording of the motion.
Thank you. So just as a point of clarification then, when can we expect this report to come back? Because it is obviously not going to come back before this budget. So what is, Dr. Richard's like, no. So it's obviously not going to come back in the next couple of weeks. So what is the expectation in terms of when we're going to see this type of report coming back?
Oh, and I forgot to do this, and Dr. Lennox had already indicated beforehand and written it in pen on the motion Q2 2025, and had checked in with some staff who said they could probably get this back by the end of Q2 2025. Okay. If staff want to change their mind, now is the moment. But I see shaking of heads, so that seems like that'll be the timeline. Sorry that not to make sure that was mentioned before.
Thank you. Those are all my questions.
Thanks. Anybody else have questions before I hand the chair over to Vice Chair Johnson? Not seeing any. Pow. I really want to just thank Dr. Lennox for this. So it's something I've been emailing about staff for a little while now, and something I found really, really valuable, my learning about public health and about wastewater data and what it means and how it can help us to understand some of these things better, and just really grateful for the leadership, because frankly, not a doctor, and so struggled a lot with how do I make the case, how do I make sure I understand this, and frankly, this is one of the great things about this subcommittee from my perspective, is that we have experts here who can speak to the efficacy of doing things, who can write about these things in intelligent and thoughtful ways, and use their expertise to help us move these things forward. So very supportive of this, really look forward to seeing what the feasibility looks like, because I think if we can afford to do it as a municipality, it's only going to give us beneficial data that we can use to continue to make good public health decisions. So thank you very much. On that note, I'll take back the chair, and I don't see further speakers on the list. So at this point, we will go to the vote. All those in favor of the motion? Wonderful, that's everybody, it carries. And now, seeing as there's no further business for the Public Health Subcommittee, it is adjourned at 11:37 a.m. and the next meeting will be held on Monday, February 24th at 9:30 in the morning. Those of the public or anybody else who wants to join us in City Hall 192, which is down the stairs and then to the left-ish, we'll be going there shortly, just have a little public gathering so people can meet us. Otherwise, everyone enjoy your day, and thanks for being here.